Hello, everyone, and welcome to Henry Schein's webinar series on health concerns in dentistry. I'm Dr. Gary Severance with Henry Schein, and today we have Dr. David Reznik presenting all the new information and vital information on diabetes, the prevention, the testing, and the treatment. Dr. Reznik, welcome.
Welcome to our latest edition of Health Concerns in Dentistry. We're going to focus on diabetes as it is very prevalent in the United States, whether it be pre-diabetes all the way up to diabetes 1. We're going to look at different aspects of it, how there is the bidirectional relationship between diabetic care and periodontal disease. We're going to look at some basic information and maybe ways to check your patient's status before you do invasive procedures, such as implants or multiple extractions, etc. So thanks, Dr. Severance, and we're off and running. As always, this is just from me. This is our disclaimer slide. It shows up on every one of the presentations that I do. So our fast facts. There are 38.4 million people who have diabetes in the United States, which is 11.6% of the population. So chances of you having diabetes, diabetic patients in your patient population are strong. 29.7 million people are diagnosed, including 29.4 million adults. Undiagnosed are 8.7 million people, or 22.8% of undiagnosed adults. Pre-diabetes, 97.6 million people aged 18 years or older have pre-diabetes. That is 38% of the U.S. patient population. That is incredible. And the older you get, the greater the chances are that you're going to have pre-diabetes. 27.2 million people aged 65 years or older have pre-diabetes. And it's not quite diabetes, but there are things we can do to turn that around and make sure the patients don't progress to diabetes 2. When you look at some of the categories, I think some of the things I want to pull out from the slide is, again, the percentage of people who have diagnosed diabetes are greater than 65 is your highest percentage. The lowest is 18 to 44. So this is something that we're looking at middle age to older age groups. Undiagnosed diabetes, there's still a high percentage of people who are 65 or greater who do not have their diabetes diagnosed. The total percentage of diabetes, again, if you look, is much higher for those who are greater than 65 years. When you look at gender, more men have been diagnosed than women, which is unusual, as men tend to stay away, I can speak to stay away from the primary care provider until there's a problem. And something which I find unusual is that more women are undiagnosed. So we have more men who have been diagnosed, more women who have not been diagnosed. And if you see the numbers, it's still a little bit more prevalent in men. If you look by race or ethnicity, you can see that there are differences, especially in the level of undiagnosed diabetes. So we're all about the same with the exception of Black non-Hispanics who have a higher percent of diagnosed diabetes, but also a significant undiagnosed percentage. If you look at Asian, non-Hispanic, 5% of that patient population has undiagnosed diabetes. So again, something that maybe we can screen for in the dental setting or ask about when we're doing our medical history updates. The lowest percentage of undiagnosed diabetes is among white non-Hispanics. So again, it just gives you a little idea of where we're seeing and what we're seeing on older adults who have diabetes. During 2001 to 2020, the age-adjusted prevalence for total diabetes significantly increased amongst adults 18 years and older. So it was 10.3 between 2001 and 2004 and skyrocketed, as far as I'm concerned, up to 13.2 in 2017 and 2020. Now, serum glucose is something that we all get in our annual physicals. It should show up if our glucose is high. Some people do baseline hemoglobin A1C. We'll talk about that as well. The age-adjusted prevalence significantly increased for diagnosed diabetes. There were no significant changes in undiagnosed diabetes, so that's actually some good news. So, crude estimates for 2021, which is the latest data I could find, almost 30 million people of all ages, or about 9% of the U.S. population, were diagnosed with diabetes. 352 children and adolescents younger than age 20, or 35 per 100,000 U.S. youth, had diagnosed diabetes, which includes 304 with type 1 diabetes. So it used to be called insulin-dependent diabetes back in the day. 1.7 million adults aged 20 years or older, or 5.7 of all U.S. adults living with diagnosed diabetes, report having type 1 diabetes using insulin. 3.6 million adults aged 20 years or older, or 12% of all U.S. adults with diagnosed diabetes, started using insulin within a year. And we've all known, we've all seen on television, or we heard in some of our journals, that the price of diabetes at one point skyrocketed. And this is a significant barrier to care for those that we treat. Among U.S. adults aged 18 or older, with age-adjusted data for 2019 and 21, showed that for both men and women, prevalence, and I'm looking here at the social determinants of health to a degree, but for both men and women, the prevalence of diagnosed diabetes was highest among American Indian and Alaskan Native adults, followed by non-Hispanic Black adults, adults of Hispanic origin, non-Hispanic Asian adults, and non-Hispanic white. So if you are white adults, you are significantly less likely to be diagnosed with diabetes as opposed to, say, Native American Indians or Alaskan Native adults, followed by non-Hispanic Black adults and those of Hispanic origin. So we see a greater number of diabetes amongst some of our minority populations. And the prevalence actually varies significantly when you look at education level, which is an indicator of socioeconomic status. 13.1% of adults with less than a high school education had diagnosed diabetes versus 9.1% with a high school education and 6.9% who had more than a high school education. So again, you can see based on education level, the less education you've had, the more likely that you are going to be diagnosed with diabetes versus those who had a higher education. Adults with family income above 500% of the federal poverty level had the lowest prevalence for both men and women. Both men and women prevalence was higher amongst adults living in non-metropolitan areas compared to those in metropolitan areas. So race is an issue. To a smaller degree, gender is an issue. Education level is a huge issue, and even where you live. We do know that your health outcomes truly depend on your zip code. And so in this case, people in more rural areas are more likely to be diagnosed with diabetes compared to those in more urban areas. Those people who made a significant income, 500% of the federal poverty level, had the lowest prevalence in both men and women. So this is when social determinants of health actually help guide us to what we're seeing as far as disease states, in this case, a non-communicable disease. This is just a map to show you the difference where we were in 2004 compared to where we are today. And you can see there's a lot more diagnosed diabetes. Again, it looks like the South, which is where I'm from, is leading the way. Regretfully, we lead the way on several disease states, whether non-communicable or communicable. There are other areas that also have some high rates in New York, New Jersey, but again, a lot of this is focused in the more rural parts of our country. So what is prediabetes? We know that there are a lot of people who are being diagnosed lately with prediabetes. I think it was 93 million people. And this is a condition where blood sugar levels are higher than normal, but not high enough to be diagnosed as type 2. So 98 million Americans, more than 1 in 3 have pre-diabetes. So that means that 1 in 3 people who could be watching this presentation today may have pre-diabetes. Of those with pre-diabetes, more than 80% don't know they have it. And that is something that I think if you're going to the physician and you're unsure, ask for a hemoglobin A1C test or ask for fasting blood glucose. And there's certain things you can ask for that will help determine whether or not you have prediabetes, and easy steps, maybe not so easy, but steps you can take to reduce your risk of going to diabetes part 2. Prediabetes does put you at increased risk for heart disease and stroke, and of course, developing type 2 diabetes. It can be reversed by making lifestyle changes, such as losing a small amount of weight. I don't know how small amount of weight, 5 to 7% of your body weight is. For some, it might be greater. It might be a challenge. And getting regular physical activity can significantly lower the risk of type 2 diabetes. Since I've had some back surgeries recently, I'm not getting the amount of physical activity. And as dental healthcare professionals, one of the things that we really are talking to our patients about is limiting our sugar intake. And that is something very important when you're talking about staying at the pre-diabetes level or even escaping that level as opposed to going to diabetes 2. So how do you tell the difference? If your hemoglobin A1C reading is in the range of 5.7 to 6.4, it is considered pre-diabetes. For diabetes, it's greater than 6.5. If your glucose tolerance test is reading between 140 and 199, pre-diabetes. Greater than 200, diabetes. These are some numbers you can keep around, so when you do look into your My Chart, when you get your labs, you have a really good idea of where you stand. If your fasting blood glucose level is 100 to 125, that is pre-diabetes. Above 125, again, is type 2 diabetes. And I think it's important just to keep these numbers in mind. You might want to write them down, because a lot of times I don't do a fasting glucose and I get 2 annual checkups a year. I'm at that age. And so I know we don't do glucose tolerance test. I know we don't do fasting. We do serum glucose. And my serum glucose has been fine, and my hemoglobin A1C is fine. But these are some numbers that I think for your own health, and again, asking your patients if they know what these numbers are, might be helpful in guiding your care. So what are some of the things that are healthy to eat and some of the things that aren't? So some are obvious, like fish, cheese, and salad. And some are bad, like fried food. And I'll be honest, I'm in the South. I live in Atlanta. I have a weakness for fried chicken. That is one of my remaining weaknesses left. Water, green juice are healthy, fresh fruits, sugar-free ice cream. So I have to give a shout out to Connie, my mother-in-law. She absolutely loves sugar-free ice cream. And she is pre-diabetic, and she is about 20 years older than me. So it's really very important that she keeps her sugar intake low. Real meat, vegetable pasta, burgers without bread, red wine, and spirits seem to be fine. And when we look at the bad side, soda, we don't want our patients drinking soda. We don't want our children going to bed with fruit juice. Bread, that would be a weakness for me too, because I love bread. I'm not really into sweets and cake or ice cream. Processed meat does include that evil thing called a hot dog, which is another one of my weaknesses. Pasta with meat, burgers and fries. I'm not even going to comment, in beers and cocktails. So it gives you an idea, because nutritional counseling, again, is something that we do for our patients. And if we know that they're pre-diabetic or they're diabetic, we can offer them some really good options on what to eat and tell them things that even though you really like it, you might want to limit your intake of. So the results of A1C can help our dental team figure out whether or not we have diagnosed prediabetes. So this will be on the medical side. If the patient has prediabetes, they have a higher risk of, as I said, of cardiovascular disease and diabetes type 2. Diagnose type 1 and type 2 diabetes. To confirm diabetes diagnosis, the physician will look at 2 blood tests given on different days. They can be either 2 A1Cs, they can be an A1C plus a different test, but it takes 2 tests. And it also helps to monitor your diabetes treatment plan. I've had some patients who have presented over the years whose A1C is truly off the chart. It was several years ago, I won't go into how many, I had a patient with a hemoglobin A1C of 15.1 who needed to get a tooth out. Very seldom do I call up the medical attendings in this program and say, okay, I know I've got to get the tooth out, but this person's going to have a really hard time healing. So what we ended up doing was getting the tooth out, and I did put the patient on post-procedure antibiotics because I was concerned about healing. I am the Georgia Dental Association member of the DPH antimicrobial resistance team. We are actually doing a new study, and this is one case where I felt like maybe it wasn't truly indicated, but it was indicated for me and for the patient. I also give the patient numbers that they could contact me, and we do call up all of our oral surgery patients within a couple days to make sure they're doing okay. So risk factors include having a history of type 2 diabetes, being physically inactive, experience gestational diabetes during pregnancy, or having certain health conditions like polycystic ovary syndrome. Type 2 diabetes is usually diagnosed using the glycolated hemoglobin A1C test, which I've been talking about. It looks at your average blood sugar over the past 2 to 3 months. So it doesn't tell you what's happening today, but it does give you an average of around 2 to 3 months. Below 5.7 is normal. As I already mentioned, 5.7 to 6.4, prediabetes. 6.5 or higher on 2 separate tests indicates diabetes. I am using this medication only as an example. I am not in any way promoting this kind of medication, but we do have a lot of our patients who are on this particular medication and several like it. The one thing that we need to know is if you are doing sedation dentistry and you have a patient on one of these class of medications, they need to stop taking it a week before the procedure. I think that is one of the most important points I can make in today's presentation because of how it works. And we're going to go over a little bit on how it works in a moment. Along with diet and exercise, these are used to improve blood sugar in adults with type 2 diabetes. Also, they reduce the risk of major cardiovascular events, stroke, etc., and known heart disease. The American Diabetes Association, it really is odd when you're writing the ADA and it's not your American Dental Association, recommends that a reasonable goal for most adults with diabetes 2 is an A1C less than 7, but your healthcare provider, your medical provider will tell you what is right for you. A majority of patients taking this medication reached an A1C under 7 and maintained it. They looked at a couple different studies, one which was a lower dose versus placebo. There was a minor reduction, 1 milligram or 2 milligrams, taking 1 to 2 diabetes pills from a starting average of 8.9, got below 7%. In the same 2 studies, the majority of people reached A1C under 7. And you can look at the lower numbers versus placebo at 28%, and then the higher doses, 56 and 64%. So it really is a great medication when it's used to treat diabetes and get some weight loss. So how does it work? Well, it helps your pancreas produce more insulin, and that's what when your blood sugar is high. When one of the reasons you get diabetes is your pancreas is not producing enough insulin. It helps prevent your liver from making or releasing too much sugar, and it slows down food leaving your stomach. It basically makes metabolism a lot slower. And that's one of the reasons we have to stop it before doing sedation dentistry, because your metabolism does slow down and you sort of feel full all the time, which means you're going to lose some weight, but it also means that those medications may hang around a little bit longer than your dentist would want them to. Type 1 diabetes, the pancreas doesn't make insulin or makes very little. As we know, insulin helps blood sugar enter the cells in your body for use as energy. Without it, blood sugar can get into cells and builds up in the bloodstream. High blood sugar is damaging to the body and causes many of the symptoms and complications of diabetes. Diabetes type 1 was once called insulin-dependent or juvenile diabetes, but it can develop at any age. We think it might be caused by autoimmune reaction. This reaction destroys the cells in the pancreas that make insulin, called beta cells. This process can go on for months or years or any symptoms appear. Some people actually have genes that make them more likely to develop type 1 diabetes, but even there are a lot of people who do have this gene who never develop diabetes. A trigger in the environment, such as a virus, may also play a part in developing type 1 diabetes. When coronavirus was, a lot of people were getting it. We were seeing an increase in the number of people who had diabetes. There's an example. Very important to realize when it comes to type 1 diabetes or insulin-dependent diabetes, diet and lifestyle habits do not cause this. Now, do we still want to have physical exercise? Do we still want to keep weight under control? Do we want to try to live our best life? Of course. But people who have diabetes type 1, diet and lifestyle had really nothing to do with it. What are some of the symptoms? A lot of urination, often at night. You're very thirsty, lose weight without trying. Well, that's something I would shoot for, but it's not happening. Are very hungry, have blurry vision, have numb or tingling hands or feet, feel tired, have very dry skin, have sores that heal slowly, have more infections than usual. So these are a lot of common symptoms that people have. Blurry vision, well, at my age, my vision's a little blurry. Found out I have cataracts, so I have to have that taken care of. Tingling in my hands and feet is more likely due to spinal issues than they are something like this, et cetera, et cetera. If you're a mother and have children and you're a hygienist and you have a job full-time and you have A, B, and C, or you're a dentist and you have all these different things in life, you're going to be tired. So the basic thing is when you look at all these symptoms together, if all of a sudden you're urinating more at night, you become really thirsty, and you're losing weight without trying, those are signs and symptoms you need to go see your primary care provider. Being very hungry, well, there's reasons for that. No or tingling hands or feet. I know when I hold my phone too long and I'm playing with it, my hand sort of feels weird. If you live in a dry environment, you're going to have dry skin. Sores that heal slowly, again, another reason to see your primary care provider, as well as more infections than usual. So how often, these are questions that I'm posing to a group of people that can't respond, but I think these are questions I want you to think about. How often do you obtain the latest hemoglobin A1C for patients in your practice? Is it possible to check hemoglobin A1C in your offices prior to invasive dental procedures such as implants, oral surgeries, periodontal care? Do you check blood glucose levels in your office prior to invasive dental procedures? So I did one of the best site visits I have done in the many years I've been doing them. And the only thing I saw that I was a little concerned with was, well, hemoglobin A1C numbers were entered at one point, but they weren't entered on a regular basis. And so that is something that we really need to follow up on. Is it possible to check hemoglobin A1C in your office? Well, we're going to discuss that. We can even discuss the blood glucose levels as well. So what is the hemoglobin A1C? It is the gold standard test used to diagnose and monitor diabetes and has been incorporated into population health performance metrics for quality care. Point-of-care testing for hemoglobin A1C provides a quick and easy, reliable method for monitoring diabetes. So you can have the patient can check their hemoglobin A1C, or this might be something you can do in your office before on a new patient exam, on a new case that's coming in for comprehensive care. You want to make sure that the patient's diabetes is under control so you get the best outcome. And I think that's the important point that I'm trying to make. In dental office are novel settings. Now, this study is a little old, but it still makes the most sense. I'm going over two studies that were published in 12 years ago, but they make so much remarkable good sense that we really need to take them into consideration when we're looking at the benefit of those we serve, our patients. Dental offices represent novel settings to reach millions in the United States who see a dentist during the course of the year, but who do not see a physician. We want to have pretty smiles. People have toothaches. They want to avoid going to the physician. So we actually have a lot of people who see us go to the dental office, but do not go to the medical office. So dental offices can serve as additional sites to identify health issues amongst diverse groups of patients. There was another study that was published in Public Health Reports that same year. Regardless of setting, the majority of respondents were willing to have a dentist conduct screening. Now, these are screenings, not diagnosis, so I want to be very clear. Screening for heart disease, hypertension, diabetes, HIV, hepatitis, and to discuss results immediately, provide oral fluids, finger stick, blood pressure measurements, height and weight, and pay for up to $20. Respondents reported that their opinion of the dentist would improve regarding the dentist's professionalism, knowledge, competence, and compassion. The fact that the test was not done by a physician was ranked as the least important potential barrier. So this work that was done by Drs. Greenberg and Glick really still is the gold standard when we look at what people think about getting tested or screened for things in the dental office. So what is a CLIA-waived service? The requirements are based on the complexity of the test and not the type of laboratory where testing is performed. And back in 2003, the CDC and CMS published a final CLIA quality system laboratory regulations that became effective in April of that year. Under CLIA, a laboratory is defined as a facility that performs testing on materials derived from the human body for the purpose of providing information for the diagnosis, prevention, or treatment of any disease or impairment of assessment of the health of human beings. So the question before I go on, without a CLIA waiver, can you test the blood of a patient for, say, hemoglobin A1C? And the answer is no. And so we're going to go over a little bit more like that. As defined by CLIA, waived tests are categorized as ones that even Dr. Reznik could do. I mean, a simple laboratory examinations and procedures that have an insignificant risk of erroneous results. So really, truly specific tests. We have had it for oral fluids for HIV and hepatitis C. We have finger stick tests for glucose levels for hemoglobin A1C. The FDA determines the criteria for tests being simple with a low risk of error and approves manufacturers' applications for a test system waiver. It is relatively easy to enroll into the CLIA program by completing an application. Now, these applications, this is a federal program, but there are different state requirements. I know the requirements in California are different. They may be different in New York. In the state where I am located, we would just have to join the CLIA program. A list of state agencies is available at the websites above, and there's a phone number to call. You can actually look at the FDA using AI these days and look and see what tests are categorized as CLIA-waived tests. But if you have something as important as an infectious disease like HIV being CLIA-waived, meaning that it is really hard to mess it up, hemoglobin A1C or glucose are really simple and just a way of monitoring or screening. So I think it's really important that we look into that because if you're doing a big case, you really want to know where your diabetic patient stands. So can you just go ahead and order from Henry Schein a hemoglobin A1C point of care test? The answer is yes. My dental assistant went ahead and did it for me. Can you order simple glucose tests? Yes. But in order for you, the provider, to use them, you must have a CLIA waiver. So I am in a building that has a lab, a real, college of professionals lab in here. I don't need a CLIA waiver. We can do point of care testing if we so choose. And we have relatively up-to-date information because of an EMR and EHR. But I've helped people set up HIV screening as a part of routine dental care in many places across the United States. This is a whole lot easier. And the reason it's important is because we do know that diabetes and periodontal disease are multifaceted and bidirectional. So we really want to know increased risk of periodontal disease with high blood sugar levels. Nearly 22% of individuals with diabetes experience periodontal disease. Periodontal infections can lead to elevated blood glucose, so it makes making diabetes management more challenging. So this is how it works. If you have uncontrolled diabetes, you might have bad periodontal disease. If you get the periodontal disease under control, then you might have better hemoglobin A1C outcomes. So this is a really important relationship. The ADA, and I think it's both of them, know that diabetes and periodontal disease have this bidirectional relationship. High blood sugar increases periodontal disease risk. Gum disease or periodontal disease in turn complicates blood sugar control, potentially raising A1C levels. Type 2 diabetes individuals are roughly 3 times more likely to develop dental problems than those without diabetes. So again, we want to help our patients stay in control of their diabetes through nutritional counseling, through excellent periodontal care, primarily performed by our dental hygiene teams, which are, at least in my program, I could not live without. Our dentists can do this as well, but it really helps us find out where our patients are. What are some of the impacts of having diabetes? There are saliva changes. It can it can cause dry mouth, can alter saliva production, and we know that saliva helps lubricate the mouth, washing away the debris and preventing certain bacterial or even fungal growth. So bacteria thrive in this environment, combining with food to form plaque. Plaque and calculus formulation, if plaque isn't removed, as we all know, it accumulates at the gum line, hardens into calculus, and can contribute to periodontal disease. So we have diabetic patients really need our attention. How often do you recall your patients with diabetes? Is it every 6 months on well control? Do you go 3 months or 4 months? These are questions that you really need to think about when you're looking at our medical dental integration. Can we get the hemoglobin A1C from our medical providers? Yes, but how recent is it? If it's more than 3 months old, to me, it is no good. Can you call up the medical office and ask, or tell the patient and ask that you get a hemoglobin A1C drawn? Sure. Can you do it as a point of care and test, screening, and alleviate another trip to the physician for your patients? Yes, you can, as long as you have the CLIA waiver. So that's why I sort of was promoting the point of care testing at site, because it really is a benefit to those that we serve. Again, many people with good income, good education, etc., or people who've been through diabetic training courses, and the patients that we see here, they are really keeping up to date with their hemoglobin A1C and glucose. Do I trust somebody knowing their hemoglobin A1C? I don't know. And I don't think that doubt is worthwhile. I really want to be able to look at the risk stratification for the people that I'm treating. Again, people with diabetes often exhibit an intense inflammatory response to oral bacteria, and we've already talked about impaired wound healing. So if you're doing oral surgery, like I was on that one particular patient with the hemoglobin A1C off the chart, I was concerned about delayed wound healing. We did sew up the socket. We did everything I possibly could, wrote antibiotics, did a pre-procedural rinse, and everything was fine. Thank you. Again, back to that bidirectional relationship. Diabetes and periodontal disease have high blood sugar increases the risk of periodontal disease. Periodontal disease complicates blood sugar control. So diabetes are, as I mentioned earlier, 3 times more likely to develop dental problems. Common oral symptoms, and this is sort of interesting, or mouth soreness, bad breath, probably due to xerostomia, chewing difficulties, again, probably secondary to xerostomia, tooth loss due to caries or periodontal disease, candidiasis, burning mouth syndrome. So this gives me the opportunity to show a few slides from my first set of jobs, which was managing people with HIV before there were treatment. This is a case of pseudomembranous candidiasis. So this can be seen in a person with HIV, an uncontrolled diabetic. They can be seen in people who use asthma inhalers and who do not rinse out afterwards. There are multiple reasons that a person can show up with candidiasis. They're not diagnostic of any particular disease, but this is what it looks like. You can wipe it away, leaving red or bleeding surfaces. This is the erythematous form of candidiasis, previously called atropic candidiasis. It tends to show up on the hard and soft palate and the dorsal surface of the tongue. Patients will complain that their mouth burns or burning mouth syndrome, or that their tongue burns, especially when having salty or spicy foods or acidic beverages like orange juice. And here's a picture of it on the tongue. So again, just to go over, Pseudomembranous candidiasis can be associated with diabetes. Erythematous candidiasis can be associated with diabetes. Since it's a fungal infection, it's a kissing lesion, and so that's why you look at the dorsal surface of the tongue and or the hard palate to see if they're showing up at the same time. Treatment is pretty easy. This case would be what I would consider a mild to moderate case, so topicals will work. One of the most prevalent topical written in the United States is nystatin. My issue with nystatin, it is a 50% sucrose suspension, and that's not really helpful when you're trying to get sugar levels down. There is no reason to swallow nystatin. Nystatin is a topical medication. It does cause GI distress if you do swallow it, and so that's why I have issues with nystatin. I did taste a sugar-free formulation of nystatin in 1999 at the Association of Nurses and AIDS Care Conference in San Antonio, and it's something I still remember to this day. There's a reason it has all this sugar. I prefer clotrimazole troches, which are lozenges, which take longer to dissolve. Just giving you a little bit of heads up on different treatments for candidiasis. The same goes for the erythematous form. It's mild to moderate in presentation. A topical will work. So just giving you a little bit of candidiasis treatment I couldn't resist. So managing oral health care, control blood sugar. That is the number one thing people can do to prevent gum disease. Regular dental appointments, they really need to see us to get professional cleanings that are essential to managing oral health. Really going over oral hygiene, brushing, flossing, using antimicrobial mouthwashes when indicated are crucial. Understand for us the link between diabetes, this bidirectional link between diabetes and oral health care. And then, of course, smoking cessation. Again, another service that we offer in the dental field. We can do nutritional counseling, smoking cessation. There's so many different things that we, as part of the primary healthcare team, do. Remember, managing diabetes effectively contributes to overall well-being, including oral health, and we want our patients to have great overall well-being. The dental team, and I will say this is invaluable when it comes to managing almost any dental disease that we have. I literally had a patient who came in who had a stroke a month earlier. She wanted to get these teeth out. She was quite adamant about it. It took one of my remarkable residents a true 30 minutes to talk this individual out of getting those teeth out. Knowing the status of our patients, our hemoglobin A1C or blood glucose of our patients will literally determine risk stratification before invasive procedures. So since we know hemoglobin A1C is 2 to 3 months, we might want to get a blood glucose. Again, the patient can bring their own and perform their test in your office. That's fine. Or you can get the CLIA waiver, write the little check, and you can do it in your own office and do it that way. We have the tools and ability to help our diabetic patients by controlling periodontal disease. Due to the bidirectional relationship between periodontal disease and diabetic control, the dental team is a vital component. We're a vital component to overall well-being and care. You can't be healthy without oral health. That is probably what will end up on my tombstone one day. So, thank you for time and attendance. Our next update is coming in August. I hope to see many of you at Thrive Live 24 this year in Las Vegas. And let us know what you'd like to cover on our next health concerns in dentistry. So thank you for your time and attendance, and I'll turn it back to the wonderful Dr. Severance. Thank you.
Thank you, Dr. Reznik, for that great information as always. And thank you for watching. If you have any questions, concerns, or ideas for future episodes, please email us at webinars@henryschein.com. And please subscribe to our YouTube channel by clicking the subscribe button below. It'll allow you to be notified with any new episodes. Until we see you again, please stay safe and stay informed.